Dr. Marian for her talk on orbital fractures.
Good morning all. At the outset, let me thank KSOS and Engineer Madam for giving me this opportunity. So today my topic is very specific, like when to intervene in orbital fractures. As we know, the treatment of orbital fractures, the initial step is to rule out any intraocular globe injury. If so, that is our primary priority. Then we can observe and with the ice compressors, steroids for 1 to 2 weeks, initial phases, give antibiotics, nasal congestants, and ask the patient not to blow the nose. And in multiple, like comminuted fractures, we need a multidisciplinary approach, including facial-maxillary surgeons as well as neurosurgeons. So before I go to the specific indications, these are the 4 types of orbital fractures we come across. Type 1 is orbitozygomatic fractures. Here the majority of the work is done by the facial-maxillary surgeons. Type 2 is orbital fractures, where ophthalmologists are primarily involved. And 3 is involving naso-orbitoethmoid complex. Naso-orbitoethmoid complex fractures, where we can get injury to the nasolacrimal system. And the 4th is the comminuted fractures, where it's not working. Comminuted fractures where multidisciplinary approach is needed. So coming to the indications, broad indications of surgical intervention, we have to intervene in enophthalmos, hypophthalmos, diplopia, large fractures, oculocardiac reflex, complex or comminuted injuries, and progressive intraorbital nerve anesthesia. So what's the timing of the surgery? Immediate, that is within 1 or 2 days or even 3 days. White-eyed blowout fracture, I will come to the details. Then gross enophthalmos or hypoglobus, that is the globe has gone to the sinus, or non-resolving oculocardiac reflex. This is a 3 indication where you have to intervene immediately. Second is early intervention, like that is within 2 weeks, diplopia with a muscle entrapment on imaging, more than 2 millimeter of enophthalmos. I have put it in italics because this indication now is being questioned in many of the studies. And third one is large fractures, that is involving more than 50% of the flow. The late intervention is after 6 weeks. So we will discuss each ward. First I will start with the pediatric blowout fractures. So in pediatrics we can get trapdoor fractures or white-eyed blowout fractures. So trapdoor, I have shown the picture, is a relatively very small fracture with clinically significant muscle entrapment with the oculocardiac reflex. It needs immediate intervention. White-eyed blowout, here the patient will not have any symptoms of ecchymosis, congestion, nothing, but have features of orbital fracture, and it can lead to ischemia and fibrosis. It should be repaired within 48 hours. So this is a patient admitted in a multi-speciality hospital with a history of nausea and vomiting, and ocular motility examination showed limitation of elevation, and the CT scan showed a trapdoor fracture. We corrected immediately, like even the patient presented to us after 3 days, we corrected immediately, and he resulted in a very good outcome. This is an adult presented to us with orbital fracture following functional endoscopic sinus surgery, but was not responding to the oral steroids after 2 weeks, so intervened, and the diplopia has subsided. This is another patient, again fracture post steroids not improving, so we did surgery after 2 weeks and the diplopia has improved. Coming to the medial wall fracture, medial rectus entrapment, patient can have epistaxis. Always look for the CT scan clearly. I will show another case later. So roof fracture is, isolated roof fractures are extremely rare. It's managed along with the neurosurgery department. The main indications to intervene are presence of CSF leak or necessity to retrieve displaced intracranial fragments, or ophthalmic signs of compromise on vision, or large displacement of fragments which may act as mechanical impediment or significantly alter intraorbital volume, producing enophthalmos or exophthalmos. So this is a case report published in Indian Journal of Ophthalmology, where a fracture fragment was pressing on the globe, causing choroidal effusion. fracture correction done and the vision has improved. So when will you intervene late? Late intervention can be either primary or secondary. Primary intervention means patient has not undergone any intervention before. Secondary means patient had already undergone an intervention presenting with late sequelae of either persistent enophthalmos, implant migration, optic nerve injury or eyelid abnormalities. So she is a 23-year-old girl, RTA, status was fracture reduction 6 weeks before, presented to us after 6 weeks. BCVA, right eye 6/24, N18. So this is her clinical picture. And look at the ocular motility. Only abduction is present, all other movements are restricted, but she has got a very good correction of enophthalmos. So this was her original CT scan where you can see a large fracture and you can see an implant. And the implant, if you look carefully, it is almost reaching up to the apex. So since she was not responding to steroids and she had chronic pain, vision was reduced because of the choroidal rupture. So she underwent implant removal with the muscle release followed by orbital reconstruction as a step 1. But still she had residual lid retraction and squint. Later she underwent squint surgery and lid retraction correction with cartilage graft. And she was given little bit fillers for the infraorbital hollowing. So this is the final picture. So there are sometimes triple trouble. You can have hypoglobus, enophthalmos as well as squint. So it needs stage surgery. So when not to intervene, that is also very important for us. So he is a 15 years male presented to us following fall from bike with diplopia. You can see the restriction of abduction. So this is a CT scan picture. You can see a fracture in the lateral wall. But in this case, the FDT was negative. So all persistent diplopia with the fracture, no need to intervene. Differentiate between paralytic strabismus, restrictive and combined. Force reduction test has to be done. Acute phase surgery is not indicated in paralytic strabismus. So this is another case, again presented to us after 2 weeks. You can see a lid laceration being sutured, adduction and abduction restricted. If you look carefully in the scan, there is a hematoma in the medial rectus. Even though there is a fracture in the medial wall, the muscle is not entrapped. There is a hematoma in the medial rectus. So the steroids was continued and he has improved and diplopia disappeared. So to conclude, complete ophthalmic evaluation is really needed in all the injuries. Rule out globe injury. When to intervene depends upon the type and location of the fracture. Always differentiate between paralytic component and the restrictive element. Always get the help of OMFS as well as neurosurgery department in indicated cases. Thank you.
Thank you, Dr. Marian, for that comprehensive presentation on Orbital.